It's the 21st of February, 2020. This is the RheumNow podcast. I'm Dr. Jack Cush, executive editor of RheumNow.com. You know, I just had my teeth cleaned today. I'm wondering if my CCP antibody levels are up. Do you have vitamin D fatigue? Lord knows I do. And a startling new revelation on the acronyms BARF and VOMIT and their applicability to rheumatologists. We'll start with a great review article, actually a meta-analysis from Nicola Dalbeth and Philip Robinson from Way Down Under, where they talk about colchicine toxicity. 35 studies, I think 8,000, 9,000 patients. They reviewed the toxicities of colchicine, a drug I no longer use. Check out QD78 on YouTube, or the video I just did, the QD clinic called My Acute Gout. But nonetheless, colchicine gives you a higher risk of things you know, diarrhea, a 2.5-fold risk. 20% of patients will get diarrhea on colchicine. GI events, almost 20% there too, 1.7-fold higher risk. Liver toxicity, I didn't know about. It's almost significant at almost 2%, 1.9%, but not quite significant. Neither was muscle events. There were no reports of neuropathy, deaths, or infections with colchicine. Is it a safe drug? Is it a 200-year-old drug? Yes, it is. Do I use it? No, I don't. Congratulations to those of you who do. There are better ways and easier ways to manage gout. According to the CDC, they came up with some new numbers on the effectiveness of this year's seasonal flu vaccine. And drumroll please, the data from October to January says that the flu vaccine was 45% effective in preventing medically attended, laboratory confirmed cases of influenza. That's half empty or half full. Clearly, we're not doing a good enough job getting a large number of our patients vaccinated, so there's a half-empty kind of story. But knowing that half of them benefited from that is still a good tune, and it only gets better in subsequent years. Again, I think it's an important intervention for those important patients who really need it. If you were at the great conference this past week in Maui, RWCS, the Rheumatology Clinical Winter Symposia, we had a number of great lectures. You can go to that website and see them and hear them. Dr. William Bugbee, an orthopedist and great friend to many rheumatologists, he's from La Jolla, had a fabulous set of lectures on issues that we're really concerned about. He laid out these two acronyms, BARF and VOMIT. BARF stands for, guess, blindless application of radiologic findings. BARF. Can you spell it? VOMIT stands for victim of medical imaging technology. I think there's a lot to be said here about the appropriate use of imaging. A recent tweet we put out says that in a study of 319 women with rheumatoid arthritis, 30% had a high rate of depression or higher than expected rate of depression compared to only 12% in the control population, suggesting that this was significantly higher. And more importantly, that depression was associated with disease activity and disability scores as measured by HAQ. Now, this was a study of women. Would the same be seen in men or a mixed population? That's not been, it's been hinted at in other studies. It seems like this could be something more prevalent in women more so than men, but it is something that we generally don't pay enough attention to and probably should. I hate to break this to you rheumatologists. You guys love methotrexate. You love, morning stiffness. You love vitamin D. You test for it. You treat it. You vitamin D crazy rheumatologists. But unfortunately, in a study of 169 patients looking at disease activity and whatnot, and number of measures, including fatigue, vitamin D levels were not associated with fatigue. Although it's often stated that you might feel bad because of vitamin D, and then when we supplement it, you could get better. Well, that's actually not true based on this cross-sectional analysis. Yet, fatigue was associated with disease activity and psychologic distress and pain, but vitamin D levels, sadly so, were not. A study from the Slovenian National TB Registry looked at the rate of getting TB amongst the population of people who are taking TNF inhibitors, largely RA, but AS and PSA included. 6% of their 2,500 patients were required to take TB chemoprophylaxis for LTBI, and that occurred in both RA and PSA. A few, something like 6 or 8 patients developed TB in that population, a very low rate, and 2 patients died from TB. So that's nothing to shirk off. The rates that they noted of TB incidence for their TNF inhibitor treated population was 45 to 51 PSA and RA, respectively, I believe, per 100,000 patients. In the United States, the risk of TB is roughly 3 to 5 per 100,000 patients. In Slovenia, they have a similar rate, actually. It's not an endemic country. The rate is about 5 per 100,000. That means an RA patient who goes on TB therapy in Slovenia has a 10-fold greater risk of getting TB. That's about the numbers that have been thrown around in the past. A 6 to 9-fold increased risk when you're exposed to TB and have an inflammatory disease like RA, PSA, or AS. Some lessons from Slovenia that are useful here in the United States, UK, Australia, etc. The FDA has approved diclofenac gel, also known as Voltaren gel, for patients with arthritis pain and osteoarthritis. It is suggested that it can be take up to 7 days to work, and it can be used for up to 3 weeks. If you're going to use it more than 3 weeks, consult your local rheumatologist, of course. A reasonable study was done on RA patients and the risk of periodontal disease. 139 patients had dental exams and evaluations, and these patients who did have periodontal disease, and they had 3 or 4 different measures of periodontitis, showed that it was highly correlated with anti-CCP antibodies in those individuals. This has been brought out before. I think this is another study that reaffirms those findings. I posted a Still's disease report. 14 patients from mainland China treated with tofacitinib for refractory adult onset Still's disease. Refractory, we would assume, to IL-6 therapy, methotrexate, steroids, because in that country they don't have access to IL-1 inhibitors. They were given 5 milligrams BID of tofacitinib, and the results were really quite striking. I think it was 50% of them went into complete remission, responses usually within a month. There was 6 patients had partial remission. There were 2 patients who didn't respond at all. It could be an alternative therapy. It is not FDA approved. It has not been studied. But there are a number of anecdotal reports now showing that tofacitinib and other JAK inhibitors do work in a number of conditions, including alopecia universalis and atopic skin disease and dermatomyositis, and we can now add Still's disease probably to that list. Like to see some studies in this area. Georg Schett published a nice piece in Science and Translational Medicine about the effects of JAK inhibitors on osteoclasts, suggesting that inhibiting JAK may result in an increase in osteoblastic function without affecting osteoclastic activity, and that may be one of the many reasons why JAK inhibitors have been shown to retard the development of erosions in rheumatoid arthritis. We're talking about baricitinib and tofacitinib here, where they, in animal models, they actually used them and showed that you could get upregulation of osteocalcin and Wnt signaling as indicative of osteoblastic activity. It's a nice new mechanism for maybe how JAK inhibitors might work in inflammatory arthritis. Lastly, I'll end with the reminder report that finally came out from Dan Solomon in Annals of Internal Medicine this week on the safety of methotrexate. As you know, Dan reported the results of almost 5,000 patients exposed to methotrexate in the CIRT study, CIRT, that's the cardiovascular risk intervention trial in high-risk cardiovascular patients, not arthritis patients, who got methotrexate or placebo, and he showed you the toxicities. And we know there's a 17% increase in mild to moderate toxicities. Most of the things that you're aware of. A few of the high points that you should take home from this, taken from a non-rheumatoid population. Methotrexate pneumonitis seen in 6 people on methotrexate, and no cases, or 1 case, on placebo with a hazard ratio of almost 7, and that was a significant difference. All these people were on low-dose methotrexate, 15 to 20 milligrams per week. All of them were on folic acid. Pneumonia was not increased in patients taking methotrexate, whereas all other infections, non-serious infections, were slightly increased. Leukopenia and anemia had about a 36 to 46% increase. That was significant, but there was not an increased risk of thrombocytopenia when taking methotrexate, and pancytopenia was rare. Skin cancers were seems to be the headline. A lot of other reports on this report. I don't think that's that important, but skin cancers twofold increase in patients taking methotrexate, and that's been reported in RA patients on other DMARDs too. So it's hard to say what that means. Cirrhosis was seen in 5 people on methotrexate, and none of the people taking the placebo comparison. All the patients who developed cirrhosis were diabetic. None of them were drinking alcohol or heavily into alcohol, and 3 out of the 5 had repeated LFT elevations, meaning more than 5 out of 9 LFTs were within the abnormal range, and none of them were sky-high elevations of LFTs. They were just 42 to 86 transaminitis kind of elevations. That's it for this week on the RheumNow podcast. Check out RheumNow.live. We still have registration open. It's going to close soon. There's 16 hours of CME, a weekend away from work. Friday to Sunday, you'll be home watching 60 Minutes at 6 p.m. on Sunday. The meeting's in beautiful downtown Fort Worth, where it's going to be 75 and sunny. We'll see you in Fort Worth in 4 weeks.